there. I'm glad to see you, and I'm excited to see what we can do to help out with your headaches. Absolutely. So yes, I am a real doctor. My license number is actually publicly searchable below. That's right, we are meeting in kind of this secret place, and so here in this secret place, we've never met. You and I have no patient-doctor relationship, and nothing that I say can be used for diagnosis or treatment, because we've never met. However, I think this will all be very helpful for self-care. I know, silly disclaimer to protect us both. But here we are. Let's get started. So first, I'm going to ask you some questions and write down your answers, okay? Let me get my little... Okay. So first, how long have you been having headaches for? Okay. There's a little thing on your face. Okay. There we go. Is that better? Okay. Alrighty. Okay. Alright. Well, let's go over the red flags first then. When did the headaches start? Okay. Have you had any new focal neurological deficits with it? Well, that means like suddenly one of your arms stops working, or you can't move your eye one direction. Something like a focal area suddenly stops working. Stop being able to speak while you're having the headache. Okay. Yeah, that would be a red flag. Let me just look over on this side. Okay. That's right. The physical exam when you walk in actually starts as soon as the patient walks in the room. In fact, in the ER, they have something called a no-touch physical exam, where you kind of Sherlock Holmes all the little details of somebody to see whether or not they have little signs of various injuries. That's what, yeah. So you'll see me kind of looking at you while we talk. Absolutely. And let's see. How about any changes in your visual acuity? Okay, any double vision? No? Okay. Okay. How about thunderclap headache? That's where very suddenly it's the worst headache you've ever had in your life. Okay. They're usually frequent and all of the same kind. Okay. How about, can I look at your eyes real quick? Yeah. Can you look up at the light for me? This light over here. Just do me a favor, just go ahead and look in the light. Okay. Are your headaches worse when you lie down flat? No? Okay. Good. How about any nausea, vomiting? Sometimes. Okay. Do you have any cranial nerve palsies? That means that suddenly, like one of your eyes doesn't work, one of your face is like drooping or something like that. You lose sensation on part of your face, your hearing changes, something like that. Okay, all right. How about altered mental status? That's where people can notice that you have noticeably different problems understanding what's going on around you. Like, you're suddenly not very awake, you're not alert, you're not oriented maybe. So in an emergency, I would ask you those questions. Specifically, I would check if you're awake. I would do what's called an AVPU to see if you're responsive to, normal communication, your verbal, or only to pain, or if you're unconscious. There's also something called a Glasgow Coma score that I can calculate based on that. Yeah, but clearly you're awake and talking to me. So that, and then that would ask you the different orientation questions. No, not that kind of orientation, my dear. What I would ask you is, do you know what time it is, right? Do you know who you are? Person, time, place, right? And what happened is kind of the fourth one. Yeah. So, but I can tell you know what we're doing here. Let's see. Oh, any immunosuppression. So do you have a history of HIV, like different hepatitis, cancer right now? Okay. If you have one of those with fever and a headache, that's a red flag sign. Oh yes, because then we're worried about meningitis. Absolutely. Okay, so those are the red flags. I'm going to ask you some general kind of living questions. Do you have a fever with your headache? Okay. Okay. All right, and then do you live in an incarcerated state, correctional facility, in a college dorm, or in like a soldier barracks? Okay. A lot of people have been sick there lately? No? Okay. All right. Good. Good stuff. All right, so like we'll get into kind of the more general things. Yeah. And of course, just looking and checking. So tell me, is it constant? Okay. Is it on both sides? Okay. Is it worse here, in the back? Or is it worse like in your temples and the back of your head? Okay. Does moving your neck affect it at all? Okay. Yeah. All right. Well, does it feel like a constant pressure, you said? Okay. Here's another question. Do you have like a runny nose on one side while you have this headache? Is it like super sharp in like one place? Like you're being stabbed in the eye or something like that? Okay. On the side where you have the runny nose, would you, if you have that, would you get drooping of your eyelid? Okay. Or like swelling of the eyelid? Okay. Does it get worse with alcohol? How long does it last? Okay. So like, okay. Well, so like cluster headaches are more frequent. So there's other things that I'm looking at while I'm talking to you, right? Cluster headaches are more frequent in males, right? And things like migraines tend to be more frequent in females. People tend to call things migraines a lot anytime they have a severe headache, but it could be a tension headache. It could be a cluster headache. People sometimes get cranial headaches that are really, or cervical headaches that are really due to problems with your cervical spine. There's all kinds of different headaches, actually, and they're all treated a little tiny bit differently. So actually, it's good to know which you have. Absolutely. This may be an odd question, but when you get this headache, do you feel like punching a wall, and like really angry, or do you feel like lying down in a room, like in the fetal position in the dark? Okay. Okay. Now, do you get an aura before you have the headaches? No, it's not like a new age thing. An aura is like right before you have the headache, you might have a weird smell, or you might see like purple or gray lights or something like that. Something might be a little fuzzy, similar to the auras people get before seizures. Okay. Okay. Well, a migraine will usually last between 4 and 72 hours. A cluster headache will be between like 15 minutes to 3 hours. Yeah. Do you feel like you can't handle the light and sound during the headache? Okay. Let me see what they put down here for your blood pressure. Okay. Is it pulsing? Okay. Do you routinely have high blood pressure? Okay. I'm just going to repeat it. I'm going to go ahead and do it with a manual. These are much better than the machine ones. They're more accurate because I'm actually listening to how your blood moves through the vessels in your arm and basically how it's, yeah, exactly. Easy, you already know. All right, well, let's get you all set. Can I have you go ahead and take some of this? Yeah. And I'll have some too. Okay. I'm just going to go ahead and put it on your right arm here. Okay. Perfect. All right. Oh yeah, this old blood pressure cuff has been with me everywhere. It's gone with me from Puerto Rico, Paraguay. I don't think I brought it with me to Korea, but it's been with me a lot of places. Absolutely. All right, make sure that your arm is here at the same level as your heart. I'm gonna need you to uncross your legs, because that can artificially increase your blood pressure. And then don't talk, okay? All right. Perfect. Okay. Alright, that's fine then. Well, headaches with high blood pressure is a red flag sign. Puts you at risk for things like stroke and so forth. So I would do a more extended blood pressure series of tests. Basically have you measured at home. If you had, you're fine. Right now, your blood pressure is 123/78. Yeah, that's not bad. It's quite good, in fact. What's your exercise regimen like? Oh, I see. Oh, that's wonderful. Very good for you. Oh, okay. Alrighty. Let me go ahead and poke on your head. Any accidents? Do you have any history of traumatic brain injury? That means that you hit your head and went unconscious at some point. Okay. Any history of severe emotional trauma before or around the time the headache started? Okay. Absolutely. And all of that is confidential here. I'm going to go ahead and poke on your head a little bit, okay? What I'm doing is I'm actually feeling for injuries, abnormalities in the skull, but because I do like some OMT, I'm also feeling for areas of tension. Okay, let me just feel your neck here. Yeah, not your face, your neck. Perfect. Nicely done. Okay, can I have you follow my fingers with your eyes? Keep your head still. Alright, keep looking, keep looking, keep looking. Okay, very good. Can I have you blink? Very good. Alright, let me have you look at this light again. Just right into the light. And then away from it. And back into it. And away from it. Okay. That's the poor man's way of checking your pupil reflex. Very important. Okay. Can I have you smile? Puff out your cheeks. Can you raise your eyebrows for me? Okay. Does this feel the same on both sides of your face here? Okay, perfect. Alright, can you hear this on this side? Tell me when you can hear it. Perfect. Other side. Same thing, I'm just doing this. And tell me when you can hear it. Nice. Okay. Oh, well, so with all that, we've already tested, and like really quick time test, we've tested cranial nerves 3, 4, 6, 5, 7, and 8. See how quick that is? Yeah, a lot of people drag it out, but that's actually not really how you do it. What about 1 and 2? Well, 2 is your vision, and 1 is your smell. We don't check smell normally. It doesn't actually give you a lot of important clinical information. Neurologists will sometimes check it for severe conditions, or I might check it if you were, there was an interesting Wilderness Medicine Society talk about if you're like running a really difficult marathon, it can be an early sign in like ultra athletes of brain fatigue or brain damage because of excessive fatigue. Yeah, but otherwise I wouldn't really check smell. Well, and it's only useful if I have a baseline at your normal. Exactly. Okay. So 2 is we can do visual. I just do a quick one usually. So, for example, usually when I'm in my military uniform, I'll have them tell me what the letters are because it's about the right thing at 3 to 5 feet. There's also a phone app you can use, right? But you've already had your visual acuity tested. Yeah. That's good. That's good vision. Let me just do it real quick. Can you tell me? Just for red flag signs, right? Can you tell me what this letter is? And this letter? Perfect. Oh yeah, and we have to alter the test for people who are from different cultures, people who maybe can't read. Absolutely. Yeah. Absolutely, yeah. Well, let me go ahead and finish the rest of the nerves real quick in your head. Can I? So let me have you stick out your tongue. Move it from side to side. Perfect. Open your mouth. Say ah. You're going to do like this. Ah. Because I'm trying to see where you're... Just look right towards the light. Here, do me a favor. Turn your head towards the light. Open your mouth and say ah. Perfect. Excellent. Absolutely. Well, that's nerves 9 and 10, and then we did 12. Can I do one more thing with 2? Okay, so tell me when you see my fingers wiggling, okay? I'm going to start them way back behind you. Oh, you have something on your face, my dear. Alright, tell me when you see my fingers, okay? Okay, you see them? Perfect. Yeah, just barely. That's perfect. Okay. Alrighty. Well, I want to do a little tiny bit of a cerebellar exam. Can you do this for me? Perfect. Can you take your ankle and run it from your knee to your shin? Alright, same thing on the other side. Great. Okay. And then can you do like this? Perfect. Can you touch your nose and then touch my finger? Alright, over here. No, you're touching your nose and then you're touching my finger. Not at the same time. Yeah, go ahead. Perfect. Alright. That's good. And then can I have you squeeze my fingers? Squeeze really hard. Come on, you can be harder than that. Perfect. Alright, go ahead and lift your knee against my hand here. Good. And this side. Oh, good. Alright. So what we've done there is like we've done quick check of your cranial nerves, right? We went 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Let's grab 11 real quick. I'm going to have you shrug your shoulders against me. Perfect. Okay. And we went ahead and did a quick check of some of your other things. So that's helpful. The reason that... So the big scary things you look for with headaches is I want to make sure that you're neurologically intact and that your essentially your cardiovascular system is healthy, right? Your family had that condition? Well, let me listen to your heart too, just to be sure. Really, the blood pressure check tells us everything we need to know, but just to reassure you, I'll listen. Yeah, absolutely. Okay. Yep, we always listen in 4 spots, right? Okay. 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 Alright. Take a deep breath. Might as well, right? Deep breath. Yeah, it's just always good to check the lungs while you're at it. And then behind you, take a deep breath. Perfect. And on this side, take a deep breath. Wonderful. Alright. Well, let's talk about treatment options. one more really important question that I need to get written down here. And that is, how frequent are these headaches? And what have you tried for them in the past? Okay. So the first thing we're going to do, different headaches have different triggers. So things like stress, hunger, cheese, chocolate, MSG, fatigue, exercise, and alcohol can actually all trigger different headaches. Exercise is a good thing. Some people have weird exercise-induced headaches. Sometimes has to do with the way their spines are, different things like that. So tension headaches typically cause stress, or the other way around, stress causes tension headaches, right? So a good treatment option for that is OMT, or even sometimes, so physicians are very divided about chiropractic. There are physicians who despise chiropractors. The problem is it's very difficult to find good evidence for chiropractic because you can't really, it's not like with, when I'm trying to test a medication, I can give you a sugar pill and a real pill to the other person, and you guys won't know which is which, but you can usually tell with what is fake chiropractic. Yeah, because you shouldn't really be cracking people in a fake way. Exactly. So then there's the placebo effect. So, anecdotally, a lot of patients that I know have gotten a lot of benefit from it. So it's something you can certainly consider for tension stuff, because you can help with neck and back. Massage therapy can help with that. Again, very difficult to do sham, but because it's safer than chiropractic, people will be more comfortable with it. And then OMT is the one with the most evidence. OMT is a special kind of manual therapy that physicians actually learn. Not MDs, usually DOs. I'm an MD, but I've been specially trained in it. So, yeah, we can do a visit about OMT sometime. You'll do some of the cracking like in chiropractic, and then some like soft tissue. Not really like massage soft tissue, more like moving the planes of fascia kind of around under your skin, basically. Yeah, really non-invasive, and it can really help with headaches. Really can get rid of the tension headaches, absolutely. So the cluster headaches are often helped with a combination, and write this down, because this is actually a combination you can put together yourself if you don't have any contraindications. But a special combination, and actually you can do migraines with this too, if you hit it early enough, right away in the beginning. It's a combination of aspirin, caffeine, and acetaminophen. Standard dose for each one. The standard dose of caffeine is about, 50 milligrams is about half a cup of coffee. 100 milligrams is about a standard cup of coffee. So you could take a cup of coffee, the standard aspirin, right? And your, the standard aspirin headache dose, and your acetaminophen. There is an Excedrin brand that if you look on the back of it, it has all three of those ingredients. You can take that at the beginning of your migraine, and that's something you can get over the counter. Helps for some people. Also a good, cluster headache right away on onset. So that's something you can try on your own as long as you don't have any contraindications against aspirin or acetaminophen. Did you know that there are more deaths to acetaminophen, Tylenol, than any other medication in the US? Yeah. So we think something's benign just because it's over the counter, but it isn't necessarily. That's right. So aspirin is not safe in pregnancy, but Tylenol, acetaminophen is. Yeah, because aspirin is a blood thinner. But so those help. Why do people get headaches? Let's talk about that more in depth in another visit, and we can go through the specific mechanisms of each one. What do you think? Okay. Basically, headaches have a lot to do with the interaction between your neurological system and your cardiovascular system, and how expanded or contracted your blood vessels are. That's why the medications that work on them tend to work on one of those two systems. So that's a good first thing to try. Another thing is trying to make sure you don't get hypoglycemic, eating 5 small meals a day. And sometimes you have to avoid cheese or chocolate or MSG. Another one that triggers migraines in a lot of people is foods that have nitrates in them. So what you'll do, here's what I recommend you do. And you can bring this to your personal doctor, right? Is put together a headache diary, okay? Try the Excedrin, as long as you don't have any contraindications, and put together a headache diary for real. And your headache diary should include what foods you eat that day. Every food, right? It should include the activities of the day, how many headaches, how long they lasted, and when they occurred, because that can help you pinpoint what your triggers are. A lot of times we don't know what they are. Exactly. Yeah. Once you've figured out your specific headache triggers, it can help them identify not just what specific kind of headache it is, but how to best take care of it. Yeah, absolutely. And basically, it can help you come up with a good diet. We can do a whole headache diet thing next time. We can do a whole visit just for that. Okay. So try and go ahead and start making a food diet. A food diet. Yeah, I'm a silly person. This is why people sometimes don't believe me. Because I am silly. A headache diary. Okay. Absolutely, it's very difficult to figure out how to decrease stress in your life. That's difficult. Try to add one short, pleasant activity that is not TV that makes you feel productive every single day. For example, 10 minutes of gardening, 10 minutes of meditation, Tai Chi, 10 minutes of something that makes you feel like you've accomplished something, drawing, something that makes you feel like you've done something. Absolutely. So, usually when we do headache medications, we divide them into two categories. Yeah, absolutely. That is an option. No, it's okay. You didn't really cut me off. That's okay. I know you wanted to finish talking about that. Acupuncture is helpful for some people's headaches, yes. It is easier to sham acupuncture than it is to sham chiropractic, because you can just put needles in random places. Yes. That's something that you can certainly look into. We can do an entire visit just on alternative stuff if this headache diary, slight stress reduction, and trying the Excedrin doesn't work. Absolutely. So the two kinds of medications are, we talk about what's called an abortive medication, which means it kills the headache, like it's something that you give while you're having the headache. And we talk about what's called a prophylactic medication. You're silly. No, neither of those are sexual medicine terms. Not that kind of prophylactic and not that kind of abortive. You're a silly one. No, prophylactic is preventing the headache. Usually those are terms that you'd use for migraines. For cluster headaches, I've never done prophylactics for cluster headaches. That's given abortive. Oh yeah, so I knew a physician that he had a head injury, and ever since that head injury, every time he was on a stressful patient rotation, he would get what he called his FMIT headache. FMIT was a very difficult rotation in residency where we were on our inpatient, and basically we, as new doctors, were running the whole hospital pretty much on our own. It was crazy. And so he would get what he called his FMIT headache. It was a cluster headache that he would get basically the entire time. So, ergot alkaloids, some of the triptans can be used for that kind of headache, right? The triptans can also be good abortives for migraines as well. I usually like to start with trying the Excedrin for migraines, because it's less side effects and less dangerous, and then try a triptan after that if that doesn't work. A triptan are like your sumatriptan, your rizatriptans, basically like your Maxalt, those ones, the ones in that family. They work on your blood vessels in your brain, and you shouldn't take them more than really, depending on your dose, right? We'll recommend somebody doesn't take more than 8 a month or 4 a month, right? Depending on the dose, exactly. They also come in injections, so when someone is having a terrible headache and coming into the hospital and not able to get better, we'll inject a sumatriptan. Or we can do an IV cocktail. In the ER, every ER doc has their own favorite IV cocktail. And then, so they have their own ways. I'm not an ER doc, I'm a generalist, but everybody's got their own, special thing. And usually it'll be a combination of some kind of Benadryl with, not Phenergan, but Zofran, and then, a Tylenol all together. Basically, you're kind of putting the patient to sleep to get rid of the headache and helping with the nausea is Zofran. But people have all different combinations that they like to use IV. So for yourself, if a triptan doesn't work, we'll sometimes do, oh yeah, absolutely. That's right. Well, so if you have some people do have a migraine with some of the neurological signs that I've mentioned. If they have that, triptans can be very unhelpful and can actually make things worse. Somebody that I know, I was taking care of them for headache, and their physician, not me, their physician had given them a triptan, despite their complicated, oh yeah, you've got something on your face right here. Had given them a triptan despite their complicated migraine. And they, in front of me, they took the triptan, and suddenly one side of their body was weaker than the other, which went away after they'd metabolized the triptan out of their body. So somebody with neurological symptoms, triptan is not usually the best option. In that patient, I started helping them with magnesium, and it actually made a really big difference. They went from having a couple of these really terrible, severe episodes every time they flew to really only having one a year. Less, actually. And what they did, because there was a study that showed that taking magnesium regularly, 500 milligrams every single day, helped to prevent. That's the prophylactic that I talked about. But you can also take it so we've tried it. I haven't seen a study on this, but in that particular person, we tried it as an abortive as well, because you can use it for different neurological things as an abortive for various neurological symptoms. Still really low dose, not like the dose that we give. There's a dose that we give pregnant women to prevent seizures of magnesium, and that's 4 grams, which is 4,000 milligrams. That's a lot. So the daily dose that I'm talking about is 500 milligrams, and for an emergency or when someone was having a bad headache, I would try 1,000 milligrams or 1,500 milligrams. So 1.5 grams or 1 gram during the episode. It shortened the episode. We went from having it be, a day and a half long to being maybe 4 or 5 hours long. Yeah. So that worked really well in that patient, and I found that taking magnesium, there are studies that have found that taking magnesium can be helpful for a lot of things, taking it regularly. But the trying it as a abortive, that's just something that I've tried in my practice. That's not something that I've seen a study for. So we call that evidence level really like a D recommendation, because it's based on, or not a D, because that's a don't recommend, C, because it's based on expert consensus only. Yeah, not based on a randomized controlled trial or something like that. But you can certainly try taking magnesium every day as long as you don't have any personal contraindications. And that's a good prophylactic to try. So initial thing you can try is you can try magnesium every day and an Excedrin when you have the episode. But you got to take it within the first 10 minutes, when you start getting that aura, if you have a migraine. Absolutely. Well, so other prophylactic medications would be like a TCA, a beta blocker, calcium channel blocker, valproic acid. I don't think I've ever used that one. But all of these are pretty heavy duty neurological medications, or beta blockers and calcium channel blockers are both hypertensive medications. So something to try if you know that you have, but we take them in different doses for headaches, specifically for migraines. It's something to try. If you know which ones you've taken, which ones you've done, you can ask your physician, hey, can we try this one next? So some medications like topiramate, It's really good for a person who also would like to lose weight at the same time. So somebody who's overweight and has headaches. Beta blocker is really good for someone who may also have hypertension. Calcium channel blocker, same kind of thing. So beta blocker is also really good if somebody has like stage fright. Somebody who's got some kind of acute problems there. Yeah, acute, like severe anxiety. It's been used for that. So we can kind of tailor somebody to hit both things, hit multiple things at once. Exactly. So the TCAs are also they're tricyclic antidepressants, so we'll also use them on someone who's also depressed at the same time, maybe. Or if I have a patient like who has fibromyalgia or another pain syndrome, the TCA might be a good choice because it's also used for other pain syndromes, diabetic neuropathy, things like that. Exactly. So you can kind of pick and choose the prophylactic that's best for you, the person. So really the thing that we do is first we try something real simple and non-invasive like what I'm suggesting, like the Excedrin, right? Then the step up after that is we'll try a stronger abortive, like a triptan, right? If that's not working and the person is taking the triptan too frequently or trying to take it more than those 4 times a month, 8 depending on the dose, if someone is taking them too many times, oh yeah, I'll get that for you. There you go. If someone is taking it too many times, then we'll add a prophylactic. And so we'll start prophylactic at a low dose while they take that at the same time, while they use the abortive for, severe headaches. And that's basically how headache management works, and you try all the different prophylactics until you have one that works. The reason you put the prophylactics on is because you want to prevent someone from getting relapse headaches or medication relapse headaches where you're taking so much Tylenol or ibuprofen every day to deal with the headaches that you're getting rebound headaches when you're off of it, and so your body is getting a tolerance to those, and so you're getting more and more headaches instead of less because your body's getting used to that dose of Tylenol, so you're putting more Tylenol, and then your body's getting used to that dose, so you're putting more, and so you're taking them too frequently, and so you get more headaches because your body's just overcoming it each time. In that case, what you gotta do is knock the medications back, deal with a couple days of really bad headaches, and then your body gets used to, it changes its receptors again. Exactly, and quiets it down. It's similar to what we do with opioids, except we don't just knock off the opioids. When someone has an opioid addiction, we trail it down little by little. But like that. Exactly like that. Yeah, that's how it works, basically. I think that's a good idea. I think that's what we should try. And then on our next visit, we'll do a quick follow-up exam, and we'll look into possible diet modifications. I hope that's helpful. I hope you've learned something about headaches and how they work. I can show you a couple things that you can do, yeah. So, one thing you can do when you have a headache, you probably already know how to massage your temples. Take deep breaths in your nose, out your mouth. Like that. Yeah, just like that. Here. Exactly like that, yeah. But there's other points you can hit too. There are a couple points. There's a point here that you can gently massage. I don't know if you can see. Right? If you feel your wrist there, you feel a little groove. Right there. Yeah, a little groove there. And then here. You can do some gentle pressure on there. And there's an occipital technique you can do. You can take a book or tennis balls and put them right at the base of your skull. So right here. If you feel the base of your skull, you can feel there's 2 kind of almost nodule bump kind of things right here at the base. Yeah, of your skull, not your neck. And what you do is you put tennis balls there, or you put a book and you lean on it. You lie down flat and you rest on it. And that'll help take the headaches away sometimes. Just as a fix for tension. These are for tension headaches specifically that these things will help with. Because what you're doing is you're pinpointing the muscle, affecting its blood flow right there, and affecting what the sensation that the nerves are picking up. So they reset and start to relax that area. Some other spots here, right here. above your eyes. In the middle, you'll feel a little groove or dimple here too. So here, the book one is an OMT technique that will actually do to you, but I won't use a book, I'll use my fingers. Here and here. These two points. And that's something that you can try on your own. Another big one, like a pain psychology technique that your pain psychologist might teach you, is distraction. Is to distract yourself with other things. And just be really aggressive about distraction. So what I would do when I'm in severe pain, psychological or physical, is I'll go through the ABCs and I'll list for each one something I like, and I'll think about it. So my husband would go through it for me, and he would start A's for apple, but I don't actually like apples that much. We'd start there. I do like B's a lot, so then we would think about B's for a little bit, and then for Charlie, we go through, C, we'd go through whatever it is, the next thing that I like, and just start thinking through that, kind of to keep myself sane. One thing that torture victims have done is they'll count during it, to kind of keep yourself sane, or count time as well, because at some point it has to be over. Nothing's gonna last forever. Exactly. So one thing that I have my pregnant ladies do is I have them, like women who are giving birth, is I have them think towards the next thing. I have, no matter what, the childbirth is not going to take longer. They're not going to be longer than a week on the induction floor. So at least not in pain like that. So have them think about next week, think about what you're going to do, think about that, envision that future, envision the end of the tunnel. It's actually even a religious technique. There's actually a religious text where it talks about how the Messiah, because of the joy set before him, endured crucifixion. The idea that thinking about the thing set before, thinking about the end road, thinking about what's going to happen after this is all over, helped him to go through that. And that's actually a psychological technique that is used for helping with pain psychology. Yeah. Thinking about the next thing. If you have chronic pain and thinking about the far future is difficult for you, then just thinking about going through each day. Think about, I'm going to survive this day. Here's my action plan to survive this day. This thing. So those are a couple psychological techniques you can use as well to help with your headaches. Absolutely. Yeah. I actually haven't heard of using EMDR for headaches, but it'd be interesting to see. I think they've used alpha stim for it. I would look that up. That's a good question. I think you should look that up. Let me know what you find if you find any interesting research on that. Yeah, absolutely. I think that's it. Any other little techniques you can do? Those are the big ones for pain psychology. Another one is with the pain psychology, learning to differentiate between the part of the pain that's coming from inside your brain and the part that's coming from a physical trigger. So for example, when you write down a list of what the pain is, a list of adjectives. Is it crushing? Is it stabbing? Is it depressing? Oh, depressing is something that's coming from inside me. I can reframe that. That's the part where I'm making the pain worse. My inside neurotransmitters are making the outside worse, if that makes sense. So how can I deal with that? How can I separate that? So instead of thinking about it as depressing, think about it as an opportunity to demonstrate my resilience, or something else like that. Yeah, reframing it. That can help. Or isolating is another one that comes up for a lot of people with chronic pain. Think about it as opportunity to get to know myself better, or instead of thinking about it as isolating, just being no, I'm not going to let this isolate me. I'm still going to spend time with other people. Making functional changes and adjustments. Exactly. Yeah. Just different pain techniques. Yep. If you have any of those red flag signs, you need to go to the ER. Especially the thunderclap headache, because that can mean a brain bleed. And that's where you're having a sudden headache. That's the worst headache you've ever had in your life. A question we usually ask, because sometimes people answer yes, it's the worst headache because they feel like it is. But we ask, is this headache different than your other headaches? And that's sometimes a better question, because most of the time you go into the ER for the worst headache, It's not a thunderclap, like brain bleed kind of headache. So, but it can be. If your headache is suddenly, like, sudden onset, all of a sudden, you should go to the ER right away. And you should tell them, especially if you have a family history of high blood pressure, stroke, or brain aneurysms. Exactly. Yeah, you're exactly right. Yeah, definitely something to consider. Alright, well, thank you very much. I'll see you in a couple weeks. I usually try things about a month, at least 3 weeks, before you move on to the next tier of treatment.